Good morning, everyone. Thank you for this opportunity to talk to you. Originally, the topic was an approach to bleeding disorders. I had to qualify it a little bit because it's massively huge. Be here all day if I had to do that. So I just wanted to talk to you about the laboratory-based approach because it's what you will be faced with when you are working up your patients, and hopefully it will give you a little bit of insight into how to work them up. So it's more practical. Okay, so I'll just be covering a little bit of physiology or pathophysiology, just going over the hemostatic system, the stages of hemostasis, the coagulation cascade a little bit, and then how to classify bleeding disorders. There's different ways of classifying it. None are more correct than the others, but just to give you a brief overview of that, a little bit about platelet disorders, and then to the meat of the topic, which is the workup of the bleeding disorders, including your history, clinical features. You can expect to see some of the screening tests, the special tests, and then I'm going to go in a little bit on the screening tests and what they mean and what you can hope to find out from the screening tests. Then a very brief approach to a hospitalized bleeding patient, and then a little bit on the management. Okay, so the hemostatic system, the purpose of it is to maintain the fluidity of blood in your body. That is really what it's about. And need a balance. So you need to, while maintaining fluidity, you need to reduce bleeding, you need to reduce thrombosis. And this whole system takes place with the via interplay of intact vasculature and endothelium, then your platelets, your coagulation factors, and fibrinolysis. So all of these things play a role in maintaining hemostasis in the body. Briefly, the stages of hemostasis, it starts off with constriction of the blood vessel wall. So a vessel that's been compromised obviously will constrict to try and limit bleeding. Then you move on to the formation of a platelet plug in order to assist in closing that void. The coagulation cascade then comes into play, and that end result is the formation of a fibrin clot. Now, we don't want fibrin clots to be forming non-specifically and without being checked. So then there's a fibrinolytic system to ensure that these clots then lyse when they are no longer needed to maintain hemostasis. This is just a brief reminder of the coagulation cascade. So this is a very old approach, old and outdated approach, but the reason I've included it here is because it is very helpful in interpreting the laboratory tests. So it's, excuse me, it's divided into your intrinsic and extrinsic pathways as well as your common pathway. And then it also shows which laboratory test can be used to test those specific pathways. So if you look at the blue section, that's the intrinsic pathway, and your APTT is used to measure problems in that pathway. The red section is your extrinsic pathway, and your PT is used there to measure that. And then the common pathway is where both intersect, and then basically your PT and PTT are involved there. So that's really the utility of this format of the coagulation cascade. It's not how it works in the body. It's more just to help us with the pathways and the interpretation of the laboratory results. So how coagulation actually works in the body is a cell-based model. It's called a cell-based model because each step takes place on the surface of a cell. So it starts off with a tissue factor bearing cell, which is usually your broken endothelial cell. So that's the first surface. And your initiation of coagulation occurs on that tissue factor cell. Then we move on to the amplification phase of the coagulation, and that occurs on the surface of a different cell now, and that is the platelet. Okay, and once your platelet becomes activated, that is the last type of cell surface that is involved in coagulation, the activated platelet, and propagation of your coagulation cascade occurs there. So what happens with bleeding? You either have a vascular abnormality, you have either a primary hemostatic problem, so your platelet plug is not being formed properly. You have an issue with secondary hemostasis where your fibrin clot is either not being formed or not being formed properly, or you have a problem with the fibrinolysis part of the cascade where there's issue with clot resolution. So many ways to classify bleeding disorders. Most commonly, it's hereditary or congenital disorder versus acquired, but you can also divide it into disorders of primary hemostasis versus secondary hemostasis. So in terms of inheritance patterns, you can also subdivide it into X-linked, autosomal recessive, autosomal dominant, but just to keep in mind that inherited bleeding disorders are quite rare, with the exception of von Willebrand's type 1 and 2, which follows an autosomal dominant pattern of inheritance. And because of that pattern of inheritance, it is more common than others. Others are quite rare, but just to keep in mind that they do exist. Acquired disorders.
Sorry, just going to speaking. You can turn off the mics. If I can ask you to turn off your
Dis vir hierdie jaar se amper sê ek narkose se appelkoors ek sê hierdie jaar nuwe smaak. Ja, I agree.
Who's that? Who's? Yeah, I think look at the people from.
It doesn't sound.
The people, and then doing this one. Who's this one? It's mute. I don't know.
The interruption. Right?
It's okay.
Is this what you want?
Yeah, I think so.
Is it?
It's just one.
It's one back. There. Okay.
Sorry about that. So more commonly what you will encounter are acquired bleeding disorders. So that would be bleeding disorders due to liver disease. As you know, most of your coagulation factors are formed in the liver. So with liver disease, you get inadequate formation of clotting factors leading to bleeding disorders. Renal disease, mainly affecting platelets here. The uremia causes a platelet dysfunction and you get bleeding from that. Acquired thrombocytopenia, acquired hemophilia, acquired von Willebrand's disease. These are autoimmune conditions, not very common, but you do experience them, and especially the acquired hemophilia and von Willebrand's can be quite scary presentations. I'll show you a picture, so it's good to be aware that they exist. Vitamin K related factor deficiencies, DIC is quite commonly encountered. That is a more consumption of coagulation factors, and then dilutional after massive transfusions, and then drugs like anticoagulants, antiplatelet drugs. These can also cause bleeding. If you were to divide it into disorders of primary versus secondary hemostasis, under primary, you would obviously consider your vessel first, with things like Ehlers-Danlos syndrome, HHT, scurvy, then platelet disorders, then inherited platelet disorders, in acquired platelet disorders. Just one thing to note is that when patients are bleeding, we often forget about the vessel abnormalities, the contribution of that, the collagen diseases and all of that. Everybody kind of just zones to the coagulation factors, the platelets, but it's important to keep in mind that's not the only abnormality you can detect. Please keep in mind that there can be vessel disorders as well that's contributing to the clinical picture here. Secondary hemostasis will be your factor deficiencies, whether alone or combined, and then disorders of fibrinolysis. These are some pictures of presentations. So here with the collagen diseases, this is Ehlers-Danlos syndrome. This is massive ecchymosis. This is how patients with acquired von Willebrand's and acquired hemophilia will present. Quite frightening sort of bleeds. So important to recognize. This will be skin bleed. So if you can see the tiny little ones, that's petechia and purpura. We'll discuss that a little bit later as well. Joint bleeds with coagulation factors, HHT, and then scurvy. We don't see it that often because a lot of our food is kind of fortified and things. But maybe with these keto and carnivore diets, we will start to see this kind of thing soon because people don't have vegetables anymore. So just please keep that in mind. Factor deficiencies, I've just put this in just to show how rare they can be actually. So you can get factor deficiencies in many of the factors. It's not just hemophilia with your factor 8 and factor 9. It can be any of them that are involved, but they are pretty rare. As you can see, 1 in a million, 1 in 2 million. The last one on the list, just please keep that in mind for later, a factor 13 deficiency, 1 in 2 million. The reason why they are so rare is mainly their pattern of inheritance. It's because it is autosomal recessive. Okay, some of the platelet disorders, again, you can divide them into quantitative, so low platelets or thrombocytopenia. This can be a result of abnormal distribution of platelets, dilutional, as we said, after massive transfusion, but that would usually be transient. And then it could be due to reduced production, so something wrong with the bone marrow and it's not producing platelets adequately, or increased destruction, which would be what you commonly see in the hospitals, immune-mediated, which like ITP drugs, your antibiotics, antifungals, a lot of them, sepsis as well, works via an immune-mediated destruction of platelets. And then the non-immune-mediated would be DIC and HELP syndrome in pregnancy and immediate postpartum. Qualitative, more your inherited disorders here, these are quite rare. We can test for them, but keep in mind that they are rare. And then acquired qualitative would be medications like your NSAIDs and clopidogrel, those kind of things. Liver disease, renal disease, uremia causes a platelet dysfunction. So here your quantity of platelets is adequate, but they are just not working properly. And in patients who have cardiopulmonary bypass. Okay, so the workup of a bleeding patient starts with a thorough history. This is very, very important because if your history is quite extensive, you can already work out what the disorder is most often and how to work them up further. So family history is important. This will give you an idea of whether you're dealing with an inherited disorder or an acquired disorder. See if you can work out if you're suspecting an inherited disorder, see if you can work out the pattern of inheritance. If it looks more autosomal dominant, X-linked, etc. Surgical history. Does this patient have bleeding post-surgery? Is there a problem with dental extractions, those kind of procedures? The nature of bleeding, a thorough menstrual history in females, medication that they're on that can be affecting the platelets or even coag factors, medical history, and then the bleeding assessment tool. This is quite important. This is a validated questionnaire that has been developed by the International Society of Thrombosis and Hemostasis. It's available online. It's quite an interactive tool. So it's got about 14, I think, categories where where you ask questions on and you score your patient and you enter your scores on the screen online, and it will churn out a score at the end of it. And this, a high score here implies a high probability of an inherited disorder, and then it can also tell you which ones to lean for. So it can be quite a useful tool, but it does come with its shortcomings. Mainly in children, it can result in delayed diagnosis of a bleeding. Clinical features of bleeding. So sometimes the clinical features, the symptoms can give you an idea of whether it's a primary defect or a secondary defect. It's not foolproof, but sometimes it can give you an idea. So for example, if you've got things like epistaxis, mucosal bleeding, petechia, and purpura, that usually relates to a platelet disorder or disorder of primary hemostasis. Just with petechia, that is usually pinpoint bleeds, usually less than 2 millimeters. Some articles say 4 millimeters. Purpura is slightly larger. That is, depending on which reference you're using, either more than 2 millimeters, but up to a centimeter. And then anything larger than that is ecchymoses. Okay, if the patient presents with delayed bleeding following surgery or spontaneous intra-articular joint bleeds or massive soft tissue bleeds, that usually implies something with the secondary hemostatic system or your coagulation factors. Okay, and then just on a side note here, if the bleeding and bruising is concealed, if it doesn't make sense with the history, the severity of the injury, and the story is not matching, please just think about physical abuse as a possibility here. Okay, so the basic screening tests. Firstly, your FBC, including a platelet count. Most labs include the platelet count as part of the FBC, but just make sure some do not. So you need that. Then the smear morphology can give you a lot of useful information. PT, which is the prothrombin time, and not the INR, please. So the INR was created specifically for warfarin managing. It is exclusively used for that. It has no utility in any other scenario. So please, the PT, and then the PTT, that's usually traditionally what would constitute a bleeding screen. Some other labs would add a von Willebrand screen, which includes a von Willebrand antigen and activity. Some are fibrinogen, some are platelet function assay. But it's fine to start off with these and then move on based on your findings. Screening. Some additional tests that you could add would be mixing studies, which is an interesting test, factor and inhibitor levels, thrombin time, von Willebrand disease multimer analysis, and then further platelet studies like flow cytometry, platelet aggregation studies. So I just want to go through some of the tests on the screening. So firstly, your FBC. What is that going to show you in a patient who's bleeding? So it's going to tell you if you have a quantitative platelet disorder, meaning is there thrombocytopenia or not. Remember, with severe thrombocytopenias of less than 10, you can get spontaneous bleed, so that's important to identify. It will give you the degree of anemia associated with the bleeding. It may give you an idea of chronicity. If there's an iron deficiency, then you know this is long-standing or repetitive bleeds or something like that. And if it's associated with other cytopenias, maybe you're dealing with the bone marrow failure syndrome that's causing the bleeding. So there is a lot of utility in the FBC. What does the smear show you? Again, quite a lot of information here. It will give you an idea of platelet morphology, so the size of the platelets. Some of your inherited bleeding disorders have giant or large platelets. You'll be able to pick that up on the slide. You'll obviously be able to exclude a pseudo thrombocytopenia, so platelet clumping. you'll be able to check that on the slide. Then you can see if the platelet granules are adequate or not. Again, rare, but you will be able to pick that up. Red cell fragments you'll be able to see to exclude a microangiopathic hemolysis like a DIC, which you'll commonly encounter in the hospital setting, ICU setting, etc. And then also your red cells can give you an idea if there's liver or renal disease. So again, this is just a different format of the coagulation pathway that I showed you earlier. Again, highlighting which tests to use. Just the purple one is the thrombin time, which measures basically, will give you an idea of your fibrinogen, conversion from fibrinogen to fibrin, and can pick up any disorders there. You can see that your PT or your extrinsic system, it's mainly factor 7 and then 10 and even factor 5. So just to keep in mind, those are 3 of your 4 vitamin K dependent clotting factors, which is why the PT is the one used to calculate the INR and for warfarin management. Okay, so a prolonged prothrombin time, an isolated prolonged prothrombin time. This means that there's factor 7, factor 5, factor 10, and factor 2 involved here. Acquired deficiencies of factor 7 would be warfarin therapy, vitamin K deficiencies, and liver disease in patients. Drugs such as your DOACs, and then a congenital factor 7 deficiency, we said that was quite rare, like this was 1 in 500,000. So it does exist, but it is rare. And then inhibitors to factor 7, which is even more rare. So a prolonged APTT, or your activated partial thromboplastin time, this refers to your intrinsic and common pathways, and a lot of factors are involved here as listed there. Prolonged APTTs would be patients on heparin, patients with non-specific antibodies like antiphospholipid antibodies will cause a prolonged PTT, and then congenital, basically deficiencies of any of the above listed factors and specific inhibitors to any of those factors. If both are prolonged, what are you dealing with here? You're dealing with possibly a pre-analytical cause like heparin contamination of that sample. So if you were not expecting it to be prolonged, please exclude that and perhaps repeat. If you were expecting it, things that are involved here is drugs, heparin, supratherapeutic warfarin, and then inhibitors, which can be non-specific like antiphospholipid antibodies, and then specific to the common pathway, which are rare. Reduced factor synthesis, so either congenital deficiencies, liver disease, or factor vitamin K deficiencies, and then factor consumption or binding, which will be massive hemorrhage or DIC. What happens if you have normal screening tests with bleeding? I've included this here because this is a very famous exam question in orals, in practicals, in case studies, and all of that. So if your screen includes your PT and PTT and your FPC platelet count and it's normal, what are you missing? Because your patient is still bleeding, but your tests are normal. You can be missing qualitative platelet disorders. You can be missing von Willebrand's disease. This is quite common. You can have a normal PT and PTT, normal platelet count, and you can have von Willebrand's disease. So please remember that it doesn't end with your screening tests, all right? You could have vascular abnormalities, which we tend to forget about as contributing to any bleeding disorders. You can have a factor 13 deficiency, very, very rare, 1 in 2 million, as we saw earlier, but it can be quite severe. So usually these patients present in infancy. The babies present with bleeding from their umbilical stump. And then you think, so the purpose of factor 13 is your fibrin clot has formed, and factor 13 assists with cross-linking of that, so to strengthen that fibrin clot. So without factor 13, the clot is quite flimsy and it breaks apart quite easily, and that's how you get the bleeding there. And remember, our PT and PTT do not include this part of the clotting process. Our PT and PTT, the process ends with the formation of the fibrin clot. So we are not assessing the strength of the clot at all. So it's not going to pick up a factor 13 deficiency. And then disorders of the fibrinolytic system. Again, physical abuse, I've put it in here. If you've done every platelet test under the sun, but you still can't explain the bruising and bleeding in strange places, please consider this. No one wants to get involved in all of that, but it does exist. So please be on the lookout. And then I put to you, is the converse true? Can you get abnormal screening tests with no bleeding? Yes, you can. And one of the things here is antiphospholipid syndrome. It will prolong your coagulation tests, but conversely, these patients present with clotting and not bleeding, but your coagulation tests are prolonged. So please keep that in mind as well. Okay, I've mentioned mixing studies, and I just wanted to chat about it because it's a very easy, quick, and cheap way to pick up inhibitors in a patient. So whether it's a hemophilia patient with inhibitors or antiphospholipid syndrome. So I just want to go through the principle of mixing studies. So it's basically still a PTT test. And what happens here, if you have your patient sample and say, suppose they are deficient in factor 8, what you do is you add normal plasma to that patient. Normal plasma will contain factor 8. So when you run your PTT again, it will correct because the factor 8 has been replaced. If, however, you add the normal plasma and it does not correct, the implication is that it isn't a factor deficiency. That's the problem. The implication is that there's some kind of inhibitor that's causing prolongation. So this can be antiphospholipid antibodies. It can be inhibitors in your hemophilia patients. It can be your acquired hemophilias and von Willebrand's disease. Okay, then bleeding in hospitalized patients. What are some of the causes here? So common causes would be traumatic or anatomical causes like surgeries, ulcer, trauma, etc. Medication, your anticoagulants, antiplatelets, non-steroidals, thrombocytopenias for various reasons, liver disease causes severe coagulopathy, renal failure via the uremia and platelet dysfunction, consumptive coagulopathy as in DIC, and then vitamin K deficiency with certain antibiotics or inappropriate diets in hospitalized patients. Rare will be inherited bleeding disorders. Keep in mind in this country and most, patients with hemophilia and severe von Willebrand's, they often know their diagnosis. They're often well-versed thanks to the Hemophilia Foundation. These patients know what's going on with their clinical picture. So you're unlikely to find a patient with these conditions that you have to work up from scratch as an adult. Acquired bleeding disorders, which would be factor 8 inhibitors, acquired von Willebrand's, they present with those massive soft tissue bleeds. Connective tissue disorders, again, the vasculature is a very often forgotten cause of bleeding disorders that we need to keep in mind. And then the vitamin C or the scurvy. So the workup of a patient, this actually works for even an outpatient. It basically, okay. So you start off with your bleeding history to decide if you've got, if you're dealing with the more inherited or acquired cause. And then based on your screening tests, which we talked about, you will work out the cause here. So we've got prolonged PTs, prolonged PTTs, both are prolonged, neither are prolonged, normal coagulation tests, and then the differentials. But we've covered all of that already. This is just a nice summary of everything that we've discussed and how to work it out. So it's a good slide to take note of in future. And then management, just very briefly, obviously it depends on the underlying disorder, which part of the coagulation cascade you're dealing with. And obviously initial management is supportive and stabilizing the patient. Specific management would depend on the cause, whether you're replacing platelets, whether you're replacing factors. If there's inhibitors, you need bypassing agents. So those are the things to keep in mind here. And then if it's drug related, obviously, then your reversal agents if they exist. Okay, that's it from me. Thank you.
Well, I'll say that's a beautiful presentation. Thank you so much. I think it's really had a lot of nice issues. You obviously mentioned everything very nice about the pressure vitamin D and clarity. And please, I'm on call, sorry. You can end that prayer.
Thank you very much. I'm not sure if there's anybody who's online who's got something to ask. And you can just turn on your mic and ask. Let's see.
Well, I have a question.
Yes.
Something that's
Go
not
ahead.
clear in my head.
Yeah.
I'm suspecting that the defect, the APTT pathway. Should I test for all the factors in one go, or should I just start with factor 8, factor 9, and then just dig deeper if those are normal? Like, if I'm suspecting a factor deficiency, should I do a big bang, or should it be a stepwise approach?
No, because a big bang, it costs a lot of money. Okay, so that's where your history comes in first. So if you want to start with factor 8, factor 9, and it's a female patient, rather not. That's where your history will guide you. That bleeding assessment tool will guide you where to start if you can narrow it down first. So try to do that. Try to look at the pattern of bleeding that's involved first. If it's the joint bleeds, if you suspect hemophilia, if the patient profile fits, if the family history fits, you can zone in on that. Check if there's liver disease, because all those factors also appear in that pathway as well. And then you can narrow it down. If there is liver disease, we don't have to go and do all of the factors. Generally, we just do factor 5. And if that is low, then we can say, okay, fine, there's liver disease. So there's ways to use your history and your clinical presentation, and obviously the severity of bleed and the duration, if it's just acquired versus a congenital long history of it, to narrow down your workup of the patient. Even though you've already narrowed it down to one pathway, you can still further narrow it down based on all of that.
And genetic testing for the hereditary causes, is it commonly available?
It's not commonly available because they're so rare. So like the platelet disorders, we don't need genetic testing. We can do that with flow cytometry and platelet aggregation studies and things. But the even more rare ones, there's a panel with in vitro overseas that we can send for. So very few places do them because they are so rare, but it does exist and it can be done.
The patient with vitamin C deficiency, or it is to actually get between that, because they could develop severe inoperability disorder.
Yeah, so that's I think that you have to measure the vitamin C, but that would be.
But without measuring the vitamin C, can you able to see that?
But that would be a case where
exclusion.
Yes, by exclusion. So you would, and then obviously your clinical picture, like the gum involvement, so the picture of the scurvy and the vitamin C kind of bleeding, because all your coag tests will be prolonged. If your clinical picture doesn't guide you, then it's going to be by exclusion, because then you're going to start working out or excluding all your coag factor deficiencies and all of that, and then you'll end up with vitamin C. But hopefully your clinical picture guides you before that.
one thing which was wondering about the role of hemorrhagic fevers, which factors do they actually destroy? Like combo creamy fever, hemorrhagic fever. They tend to have quite a lot of, they tend to present low blood levels quite a lot. And the question that was, is it consumption or is it, do they trigger any of the factors?
I'll have to get back to you.
Thank you.
Thank you very much.
Do this presentation. I think